All right, team. Well, welcome back. Last month we had the pleasure of talking to you about splinting and immobilization of the upper extremity. Today we're going to be talking about splinting and management of lower extremity injuries. With us today is myself, Dr. Mark Leader, Pediatric Emergency Medicine at Nationwide Children's Hospital in Columbus, and our suture orthotech extraordinaire, James Robinson, also here at Nationwide Children's, and our patient, Zach. The first splint we're going to discuss today is the application of the long leg posterior splint. This is used mostly for injuries to the tibia and fibula. Remember that femur fractures in children usually need a spica cast. So we're not really treating those with the long leg splint. You may think about doing that, but typically these patients who have femur fractures need orthopedic consult for spica casting in the operating room or under sedation. So when we're using the long leg posterior splint, a very common reason would be for a toddler who may have a toddler's fracture or who you're concerned about having a toddler's fracture. So as you know, the toddler's fracture would refer to a child typically around 2 years of age who could be walking and takes a fall, and oftentimes there's a twisting mechanism involved. So the fracture itself, if seen on x-ray, has oftentimes a spiral quality to it around the tibia. One point that you should remember is that if you suspect that your patient has a toddler's fracture, so in the scenario of a 2-year-old who has an injury or potentially an unwitnessed event, but acutely goes from weight-bearing to not weight-bearing on that extremity, there needs to be high suspicion for a toddler's fracture. And remember that on x-ray, the toddler's fracture may be an occult injury, so you may not see it on the initial films. And we will do a lot of splinting in our scenario, when we manage these patients in the urgent care or in the emergency room. If we have a toddler with a negative x-ray who is not weight-bearing, we will assume that they have a toddler's fracture and splint accordingly. So the long leg posterior splint is appropriate for injuries to the tibia, fibula, mostly proximal tibia and fibula, because we'll be talking about other management techniques for distal fibula and tibia injuries, such as the short leg posterior splint or an air cast, for example. But those application of those devices will be coming up shortly. So now I'm going to turn it over to James, and James is going to direct us in how to apply the long leg posterior splint.
Long leg posterior splint. Actually, let's talk about the materials first, which we spoke of in the last session. You also, of course, need your orthoglass splinting material. Comes in different sizes, 1 inch up to about 5 or 6 inch. You need your soft roll or web roll, which comes from about 2 inch to about 5 inch. You need your A-strap, which you're going to secure the whole apparatus with this, and they come from 2 inch to about 6 inch. And you need your Stockinette, which comes to about 1 inch to about 6 inch. So these are the materials that you will need to apply your splint, other than also a pair of scissors. Alright, usually for a long leg posterior splint, I have my patient lay on their belly, and sometimes you're going to actually need help with an extra pair of hands with this, guys, okay? Because your application of this splint is going to go from the tip of his toes to high thigh just below his buttocks. Okay, that is the length that you will need. So, I usually take an A-strap, web roll, whatever you have there, and you want to get the length size of your orthoglass for the patient. So I usually start at the tip of their toes, go down the length of their leg, stay close to their leg, and stop at that high thigh just below the buttocks. This is, in general, the length that you're going to need to cut as far as your material. So I'm going to lay that there. Then we're going to apply our stockinette first. And Zach, we're going to just bring your son right up to here. That's okay. Okay. So you're going to gently slip this, and now I'm going to ask Zach to lift his leg. A lot of your patients will not be able to lift their leg. Okay, you can rest. Okay. Your second piece of stockinette is going to actually come off the tip of his foot. Okay. And why do we use the stockinette? We use it to create bumpers at the edges of each splint to protect the patient's skin. Right. So you're going to start wrapping from right at the base of the metatarsal, of the fifth metatarsal, all the way down by half, okay? All the way up to our high thigh area. This is probably the largest splint that you guys will probably apply. Remember, I'm going down by half, one layer. So at this point, I'm going to ask for help lifting the patient's leg, because remember, they're injured, so they may not be able to do this for you. So at each end, I went around about 3 times to create a bumper. So once you've done that, fold your stockinette down. To create a bumper. Now, on the heel, it's real important that you add extra web roll or soft roll for the heel. That is an area where there can be a skin breakdown, so you actually want to pad that quite well. So just take a few layers of the web roll, put it right on the heel. And that will protect that bony prominence right there. Okay. So, looking at all my edges. Okay. Now I want to apply my orthoglass.
What I did earlier?
Yes. I usually do a pre-measure. Pull your orthoglass. And when you lay this to the patient's skin, you will have to do a few more cuts to get it perfectly to the size of your patient. Now remember guys, you will wet this at the sink first, one side. Then you will come over and at the tip of his foot, you want to create what we call a little lip or a toe plate. Okay? You lay that right there. And I have extra here. This is where I will cut this off, okay? You do not need to fold this back or anything like this. You will cut this off right here, and this is exactly what I'm going to do right now. Remove it from the patient. And we're going to cut this down.
Also, too, remember, if this was wet, you would probably want to wear gloves to keep it from sticking to you. Right, James?
Yeah, absolutely. So now I've got my right length. I want to cut those edges down. That should not be exposed to the patient. Pour your cotton up over the orthoglass so the fiberglass is not exposed. Do the other end exactly the same way. Okay, come back. Tuck that right nice and neatly below your bumper. Okay? Your toe plate. Now you're ready to secure this with your ACE wrap. And when we secure this, we usually start distally and then go proximally. Okay. When you apply this, their toes should be exposed so they can check for circulation. When you get to the heel, you can crimp the orthoglass, fold it down, and it creates a nice little cup for the heel. Okay. And you're going to work your way down again with your ACE wrap by half. And this point, I'm going to ask someone to help me lift his leg so I can get up under there one more time. And remember, ladies and gentlemen, your ACE wrap should be below your bumper, okay? It should not be touching the patient. Okay. All right. So, it is important, while this is hardening, you place their ankle at a 90 degree. So you gently press with the palms of your hands and you just hold until that hardens, okay? And you want them at a 90 degree, okay?
Now these patients are not going to be weight bearing, so for older patients, we're going to talk to you about crutch walking and who's appropriate for that in a few minutes. But one of the things that James will do when he's holding the splint and letting it harden is talk to the patient about discharge instructions. So what is it, James, that you would typically tell them in terms of caring for the splint?
What you just mentioned first, non-weight bearing, use of the crutches. Do not remove the splint. The splint in no way can it get wet. So they're going to have to, smaller patients, maybe toddlers, preschoolers, we have them do wash-ups. For the older kids, they would have to do baths with hanging their legs off the side of their tub. Those are little tricks they can do at home. But the biggest deal is they cannot get this wet and they cannot remove it.
So an interesting dilemma is, with younger kids, what do you do about weight bearing, being that they can't weight bear and they have this big bulky splint on? So sometimes we'll tell the families to use one of those green wagons or a traditional red wagon to get the child around. Obviously the parents can carry the child. For older children, sometimes we make a walker available to use, depending on their coordination and appropriateness. We usually limit crutches to children over 10 unless they're very coordinated 8, 9-year-old. But typically 10 and over, you're pretty safe with the use of crutches. Below that, walkers, wagons, apparatus the family may have at home that's appropriate. That should do it for the application of the long leg posterior splint. These patients then typically follow up with orthopedics as per your local specialist's advice. Typically it's a week out. Thank you very much.